but increased to approximately 6 centimeters. The lump is associated with mild intermittent aching pain radiating to the back without any aggravating or relieving factors. Prior to the history, the patient did not give any history of scrotal trauma. There was no history of fever or dysuria. There was no history of any leg swelling. There was no history of any other lump in abdomen, no history of swelling in the neck, axilla, or groin, no history of cough, chest pain, or dyspnea, no history of anorexia, generalized weakness, or weight loss recently, no history of any breast enlargement, no history of any complaints on the opposite side of the scrotum. There is no history of any comorbidities or any other illness. Patient is not on any medication. He does not have any habits or addictions. His bowel bladder habits are normal. There is no history of similar complaints in any family member. Patient is married 8 years back with two. Patient is married 8 years back with two children, one 6 years old boy and one 4 years old girl. Thus, I would like to summarize my history. Male, 35, aged 35 years, with rapidly growing mass in the right side of the scrotum since 4 months, associated with mild heaviness and dragging pain without any other contributory history. Transscrotal surgery with removal of the testicular mass was done 1.5 months back. Subsequently, the patient is having a rapidly growing lump in central abdomen with mild aching pain since 1 month. On clinical examination, the patient is conscious, cooperative, well-oriented with respect to time, place, and person. Is afebrile with his performance ECOG score 0. Body mass index is 24.5 kilogram per square meters and body surface area is 1.75 square meters. Patient has a pulse rate is 84 beats per minute with regular rhythm and normovolemic. Blood pressure is 112 by 70 millimeters of mercury in left arm supine position. Patient does not have any pallor, edema, cyanosis, icterus, or clubbing. There is no palpable supraclavicular lymphadenopathy or no palpable axillary or inguinal lymph nodes. Cardiovascular and respiratory systemic examination is normal. Patient does not show any history of gynecomastia, does not have gynecomastia.
I think, should we ask questions on history?
Better.
Yes, definitely.
So Mandar, to start with, can you come back to the first slide? We have a 35-year-old male. Yeah, I mean, just to a swelling in right half of scrotum since 5 months and lump in central abdomen since 1 month. So if you see directly, the history is very suggestive. And if you are like presenting a testicular cancer symposium, I mean, you almost hit the diagnosis in the first 2 sentences here. So, like Sir said in the beginning, like keep your view broad in the history also. So many of the negative histories you have covered up. What anything remaining if you think so? There is a lump in central abdomen. So should we have some histories related to that also?
The lump was patient present complained of the lump since 1 month. It was rapid in size. Patient felt it was indistinct and it was not associated with mild dragging pain in the mild aching pain radiating to the back, and there was no aggravating or relieving factors. It was not related to any particular aggravating factor.
So if hypothetically, if I say this 5-6 months back, the right testicular swelling was say a hydrocele, it was treated by a local doctor as you explained through a right scrotal incision, and then this is a totally unrelated central abdominal mass which has come in the further. So relation to symptoms like acidity, symptoms like bowel alteration, or anything, any symptoms related to the pancreas. So I guess in one line or in 2-3 lines, you should finish off probably that also. I know finally we are going to come to testicular. Yeah.
Mandar, what is the importance of taking the history of surgery in this patient?
I beg your pardon, sir?
Taking the history of surgery, you have taken that history of no surgery in past. Scroll down your slides. Can you hear me?
Yes, sir.
So here it is, that no history of any other illness or other surgery done in past.
So sir is asking, which surgeries do you think we should have with relation to this case?
Where you suspect that testicular tumor can happen in these patients.
What surgeries do you expect to clinch to your or correlate with your diagnosis?
When a child, this surgery is done in child when we have
Testes, a surgery for undescended testes,
yes,
that's orchidopexy.
that's very important. You have taken, but you should know why are you taking this thing. Any history of orchidopexy or anything, they are actually predisposing factor for the patients. They can have testicular tumor in future.
I think remaining most of the points are probably covered in the history.
Yeah, he's taken good history. But I think central abdominal lump, if it is there, as Ganesh has said, you must ask other symptoms also, which anyway has been told to you. Now go to examination.
Patient is conscious, cooperative, well oriented with respect to time, place, and person, is afebrile. His performance score is ECOG 0. Body mass index is 24.5 kilogram per meter square with body surface area of 1.75 square meters. His pulse rate is 84 beats per minute, regular in rhythm and normovolumic. BP is 112 by 70 millimeters of mercury in left arm supine position. There is no pallor, edema, cyanosis, clubbing, or icterus. There is no palpable lymphadenopathy in lymph nodes in the supraclavicular region or in the axillary or inguinal region. Cardiovascular and respiratory system examination is normal. There is no evidence of gynecomastia.
Dr. Mandar, please go to the slide. Yes. Why you have asked there is no evidence of gynecomastia? Why
Sir,
do you examine that particular thing? And why the pulse rate and BP is important with respect to your case? One is gynecomastia, another is the pulse.
because in case of sex cord tumors, that is in case of Sertoli cell tumors, in case of sex cord tumors, you may have evidence of gynecomastia, or in cases where the patient had a history of undescended testes, we would like to find out whether there is any hypogonadism and gynecomastia.
And how is the pulse rate important?
The pulse
Or
rate,
is
because pulse rate is important because suppose it is a testicular mass or a testicular tumor with non-seminomatous germ cell tumor with high beta HCG, then the patient will have features of secondary hyperthyroidism, and due to that the patient may have tachycardia.
Okay, good. Proceed.
The abdominal examination was done in supine position with exposure from nipple to mid-thigh with due consent. The abdomen is flat, contour is flat, umbilicus is central, there is central inverted, there is no visible lump, there is no visible pulsation or peristalsis, no scar or dilated veins, hernial orifices are normal, or quadrants move proportionally with respiration. There is no visible renal angle fullness. Spine does not show any abnormality. On palpation of the abdomen is soft, non-tender. A firm, fixed, non-tender pulsatile mass with smooth surface is palpable in the central quadrant in periumbilical region, 7 into 5 centimeters, 5 centimeters medially from both anterior superior iliac spines, and 4 centimeter above, approximately 4 centimeter above and 3 to 4 centimeter below the umbilicus. Mass has ill-defined edges and smooth surface. It does not move with respiration. Mass does not become prominent on leg raise test. On lateral position, the lump does not become prominent or its position does not change. Thus, it appears to be a retroperitoneal lump. There is no other lump palpable. Liver and spleen is not palpable. Cuff impulses are not palpable at the hernial orifices.
When you say retroperitoneal lump, there is one more test you can do in examination. One of examiner from South who used to come to KGMC, he was very fond of her. And he failed one guy because of that.
A knee elbow.
Yeah, knee elbow position. So, yeah, that's correct. Good.
On percussion, there is tympanic note elicited in all four quadrants. Liver dullness is appreciated in the right fifth interval. There is no free fluid. The normal bowel sounds are appreciated on auscultation. On per rectal examination, anal sphincter tone is normal, the mucosa is smooth, and there is no growth or mass palpated with normal fecal staining. On scrotal examination was done in standing position as well as supine position. The right testicular bulge is absent. There is a 5 centimeter linear healed scar present on the right lateral aspect of the scrotum, extending from the base to the root of the scrotum. The left testicular bulge is seen. Scrotal skin shows normal rugosity. There is no visible cuff impulse. On palpation, the temperature is normal. There is no tenderness. Left testis is not enlarged. Surface is smooth and testicular sensation is appreciated by the patient. Left spermatic cord is not enlarged. There is no swelling or lump palpated in the right hemiscrotum or the hemiscrotum. The scar is non-tender. There are no nodules palpated on the scar. The stump of the right spermatic cord is indistinctly felt at the root of the scrotum. There is no palpable cuff impulse.
Dr. Mandar, did you examine the left testis first or the right testis?
First are the left testes.
Okay. So you compare with the left testis, which is the normal one.
Yes, sir.
Okay. 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 Summarize your case.
I would like to a 35-year-old male shopkeeper with right scrotal swelling with intermittent dragging pain since 5 months, rapidly growing and not reduced by change in position, associated with history of orchidectomy, then a central quadrant abdominal lump with intermittent aching pain. On examination, there is a 6 into 5 centimeter firm, tender, non-pulsatile lump present in the central abdomen, retroperitoneal in location. The right testicular bulge is absent with a linear healed skull present on the right lateral part of the scrotum. Left testis is normal on clinical examination. Yes, I would like to give my provisional diagnosis of a right testicular mass post-orchidectomy with retroperitoneal lump, most probably due to right testicular tumor with retroperitoneal lymphadenopathy.
Post which orchiectomy?
Post-transscrotal orchidectomy.
Transscrotal orchiectomy. Retroperitoneal lump possible due to right testicular tumor with retroperitoneal lump.
So what type of testicular tumor do you foresee in this case?
And why?
Considering the age of the patient I foresee it as a germ cell tumor of the testes.
Germ cell is there. No. What in germ cell? Seminoma or non-seminoma?
Sir,
it depends on the decade, right, of presentation. Can you go one slide back? So 35 years. So out of the two, which is common?
Non-seminomatous.
I feel seminoma. What do you say, Ganesh?
Seminoma means 35 years. Fourth decade is the seminoma.
It can be non-seminoma also, but classically in 35, 45 is seminomatous.
And Mandar, if I'm in your place, I'll put a case summary. If the examiner tells me like male shopkeeper, married, 2 issues, 35 years, like 35 years male, married, having 2 children, so. So you complete that part also. So do you think we should give any DD or we should be fixed on testicular only?
Can be a case of a secondary differential diagnosis of a retroperitoneal lump with a secondary hydrocele, but the patient doesn't give any history suggestive of earlier hydrocele. The testicular points against the hydrocele are that it is a rapidly growing swelling since 5 months. The patient felt that it was firm to hard, and it was later on associated with a rapidly growing central abdominal lump, most probably a retroperitoneal.
Whether you don't have biopsy report with you.
Yes, sir.
If I say it was hydrocele operated there somewhere outside, and there is a horseshoe kidney with a tumor in the central abdomen.
Mandar, in continuation to what sir is saying, hydrocele is many times suddenly found, and if you ask, invariably 5 out of 10 people with hydrocele tell us that nahi, ab bhi aaya and ab bhi bada ho gaya. Till that almost 10-15 days prior to they come, it's all normal only.
So you just can't say it's a testicular tumor. You have to keep many things in your mind. It can be even lymphoma, lymph node mass in the retroperitoneum.
So definitely what you have negative is you don't have any straightforward bowel complaint. So say stomach related symptoms you don't have. So we understand that epigastric or upper quadrant mass which you are mentioning is not a stomach. But as sir says, lymph node mass can be a possibility. So at least have some till we reach the investigations, and if it is not absolutely straightforward, I mean this is quite straightforward, but you always keep a DD in your pocket.
Yeah, any soft tissue tumor in the gist can be there. Anything can be.
We discussed about pancreas earlier in the history. So something can be asymptomatic for some time. It can be a cyst, pancreatic cyst. So I know it is a testicular cancer case, but a DD, if somebody asks you, at least try to attempt to tell 1 or 2 things logically. I mean, not jabardasti.
You cannot jump on the testicular tumor unless you have investigated. Yes, that's the one diagnosis, but there are other possibilities also.
Okay, so let's go ahead.
Investigations.
So how will you proceed with the case?
Sir,
so your differential diagnosis is testicular tumor, most likely non-seminomatous. Now, how will you proceed? That's your clinical diagnosis.
Yes, sir. I will, since the patient has already been operated outside, I would examine the biopsy report of the patient. I would also do tumor markers, and I would, for staging purposes, do a CT, thorax, whole abdomen, and pelvis.
Okay, so Mandar, just for a minute, if this testis would have been intact and the patient would have presented with the right testicular swelling, what would be the change in, say, palpation findings you would have? Say it is a 8 by 9 by 7 centimeters right-sided testis present.
Yes, sir.
So can you first tell what may be the specific findings in palpation when you have examined so many patients like the same?
The testis would be enlarged. The surface would be smooth, or it may be nodular.
Right.
The consistency would be firm.
Firm to hard, maybe. What important thing is there next?
Testicular sensation, on eliciting the testicular sensation would be lost.
Will be lost.
May appreciate a thickening of the spermatic cord at the root of the scrotum.
You may be able to reach above.
Yes, we may be able to reach above, and we may be able to also appreciate a thickening of the spermatic cord.
And if you can transilluminate, it might be absent.
Transillumination would be absent.
Right. Okay. So we come back to
case. So you said you will look for biopsy.
Yes, sir.
Biopsy was there, or?
Yes, sir. The biopsy showed a 7 into 5 centimeter tumor with tuminica albuginea involved, lymphovascular invasion present, spermatic cord not involved, scrotal skin also not involved. The microscopy showed a mixed germ cell tumor pathology with embryonal cell carcinoma component 45%, teratoma 25%, seminoma 20%, yolk sac component 10%. Thus, this is a
Dr. Mandar, what are the points which you would like to look in a biopsy specimen of a orchidectomy, or rather say radical orchidectomy specimen? Say for in this case, you have the whole report available. So what are the important points, 1, 2, 3, 4, 5, which you like to mention or stress upon while looking for a report of a orchidectomy specimen?
the size of the tumor, then the components on grossing the components of the test is involved. That is whether the spermatic cord is involved, the tunica, or the albuginea. Hello. And the skin, whether the skin is involved. Then the next thing would be whether lymphovascular invasion is present or not, whether rete testis is involved or not. And in microscopic examination, I would like to see for the components cells, that is whether it is showing seminoma with enlarged nuclei with uniform enlarged nuclei with prominent nucleoli, or patient is having components of non-seminomatous tumors like
Can you important two things which you like to look in a non-seminomatous report, and two things which you like to look in a seminoma, which will point or further decide about the management of the patient?
Centimeters and rete test is involved. While in non-seminomatous germ cell tumor, lymphovascular invasion involved, in involvement, then spermatic cord involvement, and if there is embryonal cell carcinoma component.
Yes, for non-seminomatous, it is LVI and the embryonal component, and for seminoma, it is a rete testis and the size of the tumor. Apart from the spermatic cord involvement, or if there is total violation, if there is skin involvement, etc., that is separate. Okay. So the biopsy suggests the mixed germ cell tumor. So
how does embryonal cell carcinoma actually affects you? You just said there too, LVI, I agree. Embryonal cell carcinoma, and you have teratoma also. This
Yes.
patient is having the retroperitoneal lymph node. Suppose he did not have the retroperitoneal lymph node. So what is the significance of teratoma in primary? And there were only 1 or 2 centimeter node in the primary, in the retroperitoneal.
The patient has only teratoma in the primary, and there were 1 to 2 centimeters lymph nodes in the retroperitoneum. Then this would be classified as a good risk case.
Okay, we'll come to that later on. But here, embryonal cell carcinoma, what do you mean? Why are you worried about this?
Because this is a has got higher risk category.
Yeah, they are aggressive tumor. The embryonal cell component is actually high risk aggressive component.
they have a high chance of nodal metastasis.
Yes,
Okay,
sir.
proceed. So with this report, what next?
Sir, post-orchidectomy tumor markers were assessed. The reports were alpha fetoprotein of 5,304.8 nanogram per milliliters, beta HCG of 5,295 milli-international units, and LDH of lactate dehydrogenase of 679 units per liter. The hematological investigation.
Manda, what's the time when you have done this tumor markers post-orchidectomy? It's after 10 days, 15 days, 1 month. And what should be the ideal scenario of these markers?
4 weeks after.
It's a de novo case presented to you for the first time without any scrotal violation. What are the time intervals when you will get the markers done?
Sir, de novo case means in which the surgery has not been. I would like to
yes, for primary case to you.
Sir, ideally tumor markers for staging purposes should be done post-orchidectomy. But pre-orchidectomy tumor markers also tell us about the help us in 2 scenarios. One is that they may tell us, give us a brief idea about whether there is non-seminomatous germ cell tumor involvement. The second is that if there are very high tumor markers and the patient is symptomatic, then on the basis of very high tumor markers and symptoms, we can directly start. We can give a diagnosis of germ cell tumor and start the patient on chemotherapy.
Right.
Okay.
Yeah, so the answer you gave again, 4 weeks, it's almost correct. It's like five half-lives. So what are the half-lives of AFP and beta HCG?
Beta HCG is 48 hours and alpha fetoprotein is 5 to 7 days.
5 to 7 days. So approximately 5 half-lives is 4 to 5 half-lives is the time.
Yeah. Beta HCG takes almost 14 days to get normalized, and AFP almost 4 weeks. Okay.
Okay. And if you have a de novo case, then tumor markers, as you said, are done post, pre and post orchidectomy, but staging is with post orchidectomy, obviously.
Yes.
And risk stratification is with which
Which risk stratification?
The risk stratification is International Germ Cell Cancer Cooperative Group Score, IGCCG score, and it is done post orchidectomy.
Okay.
Where do you think it is?
It is done in advanced cases of 2B, 3, 2B and 3 stage of germ cell, non-seminomatous germ cell tumor.
So here with respect to AFP and beta HCG, where are you? S0, S1, S2, S3?
This case.
This is S2, sir.
S2 for the AFP and S2 for the
HCG.
So I think one point I forgot. I would have this thing I have in my mind. You had a very good biopsy report from outside. That was outside report, or it was reviewed at BHU?
It was reviewed at BHU.
So always review outside report in your center. So
yes.
That's what actually I was thinking, that how come he has such a good biopsy report from outside. So this has to be reviewed, just to tell everybody. So this patient, where does it fall now?
Sir, this patient falls in pathological stage T2. Sir?
Yes, go ahead.
Sir, before doing the staging, I would also like to do the imaging, because like to see the
okay, that's correct.
Peritoneal lymphadenopathy or retroperitoneal mass rather. I would like to examine that before doing the staging.
Okay, go ahead. What will you do for them?
Sir, further, the patient actually came to us with a whole body PET CT scan. The ideal investigation in for staging purposes in germ cell tumors is a whole body CT scan. It is not a PET scan, but he had already come to us with the PET scan. In the PET scan, the findings, sir, may I show you the images? In the PET scan, the findings were there were no lung nodules, no mediastinal lymphadenopathy. FDG avid nodule nodes were present in the retroperitoneum, largest size 7 into 5.5 centimeters, with standardized uptake value maximum of 13.5. Right-sided common and external iliac nodes were enlarged, with the largest node of size 3.9 into 4 centimeters, with standardized uptake value of 10. The rest, the liver was normal. There was no abnormal uptake in the right scrotum. The patient had a post-orchidectomy status. There was no abnormal uptake in the skeletal system.
So had he not come with the FDG, what you would have done?
Sir, I would have done a whole body CT scan of the thorax, abdomen, and pelvis.
Why? Suppose you have done CT scan of abdomen, there are no nodes. Will you still do the CT scan of thorax?
Sir, considering this as a high risk tumor with S2 tumor markers, I would do a CT scan of the thorax.
Even the lymph nodes are not there in the retroperitoneum. It's okay. I understand with these tumor markers, most of the time you do have the lymph node in the retroperitoneum. But if the patient's tumor, he is in a good risk category, suppose his tumor markers are less and there is no retroperitoneal disease, doing CT scan chest actually may not help you at all, but there are rare chances when you can even have a skip lesion. There will be a lesion in the chest and just nothing in the retroperitoneum. The another thing, the PET scan, which you said, that's correct, that it has no role in NSGCT, but it does have role in seminoma. Because in seminoma, you don't have high tumor markers, and it's actually routine for seminoma. Okay.
Sir, these are the CT images of the patient. In the CT scan images, sir, there is root of the mesentery is clear. Below that, there is a large lymph nodal mass which is present below the renal vessels. It is involving it is a large mass which is involving the pre-aortic region, inter-aortocaval region, as well as precaval region. Subsequently, the mass is extending below the kidneys. And also this image, this is an image in which we are seeing a mass in the right side iliac. It is involving, there are multiple nodes present both in the external and internal iliac group of lymph nodes.
Okay.
This is the PET CT scan. Beg your pardon, sir?
So it's in the field nodal involvement, or it's going outside the field of template field?
It is actually there is extensive lymphadenopathy present in the right side pelvis, pelvic region. So it is actually going outside the template.
So what he is asking you is, what are the probable causes in a way why these lymph nodes are enlarged?
Because of scrotal violations, sir. The patient underwent a transscrotal orchidectomy. Due to that, it has been seen that there are high chances of.
Okay. So just a question. On the right side, where will be the first echelion of the landing site from there? Suppose I have a scrotal squamous cell carcinoma.
Yeah, scrotal squamous cell carcinoma, it will be in the inguinal region.
Correct. So scrotal violation will also probably travel through a channel, landing sites and further. So inguinal and further to these lymph nodes. So that is one reason. What is the other reason?
Yes, sir.
The other reason is if you have such gross big lymph nodes in the retroperitoneum, at times those lymphatics are totally blocked and there is a retrograde downspread.
Yes, sir.
Okay.
So how the lymphatic spread is different from for a right testicular cancer or a left or in a left testicular cancer? How they differ? The way of spread.
The lymphatic spread of the testicular cancer is towards the retroperitoneal group of lymph nodes. On the right side, it is in the precaval and inter-aortocaval group of lymph nodes, which are known as landing sites. While on the left side, it is in the para-aortic group of lymph nodes as the initial spread. And also, generally, later on, they spread from the right to the left. There is more chance, physiologically, the nodes subsequently spread from right to the left rather than left to the right.
Yes, got it. Okay.
These are further PET CT scan images, which are also showing uptake in the iliac region. The ultrasound with Doppler was done of the scrotum with left testes. There was no abnormality seen. Thus, my diagnosis is a case of
What
post.
about CT chest? Did you do CT chest?
Actually, there were no lung nodules. There was no mediastinal lymphedema.
PET scan, you are saying.
Beg your pardon?
Okay, it's okay.
Yes. So my diagnosis is a post right-sided testicular mass post transscrotal. non-seminomatous germ cell tumor of the testis, stage PT2, clinical nodal stage 3, M0, tumor marker stage S2, thus it is a stage 3B. With high risk according to the IGCCG classification.
So how will you proceed now?
So when you say high risk, what does that mean? What does that actually convey to you?
It actually conveys that there are higher chances of systemic spread, retroperitoneal lymphadenopathy, and higher chances of relapse post-treatment.
Basically, it actually tells you that what is the prognosis of the patient. You don't decide the treatment according to the risk. You can say patient, attendant or patient, you can inform the outcome, what is going to be the outcome because of the risk factor. So is a high risk means poor risk.
Poor risk, yeah. IGCCG,
yeah, it's poor risk, intermediate, good, and poor risk.
Yes, sir.
Okay, so what do you think in seminoma? How many risks are there? Risk factor.
Seminoma has a good and intermediate risk only.
What about poor?
Seminoma generally does not have poor risk category according to the
generally
IGCCG.
it doesn't have poor risk. Okay.
No.
Yeah. So what will you do next? Any other question from Ashish or Ganesh here?
So what next?
I would further plan the treatment of the patient. I would ask the patient, counsel the patient about his malignancy, and then I would ask him about his whether his family is complete. If his family is complete, then I would go for treatment, that is chemotherapy with 3 cycles of bleomycin, etoposide, cisplatin regimen. Before doing the chemotherapy, I would also assess the function of the patient by spirometry and by DLCO. This patient does not have any risk factors, that is high age or COPD or smoking history.
So you said poor risk, no?
Beg your pardon, sir?
You said poor risk, right? IGCCG.
Yes, sir.
So if you basically see
poor risk. It is intermediate risk.
Yeah. So good risk NSGCT gets either 3 BP or 4 EPs. That is what is given by medical oncologists. And intermediate and poor risk either get 4 BPs or 4 VIPs.
You can substitute ifosfamide for bleomycin if the patient has compromised lung function.
So why I said that, because you said you will start, counsel for the 3 BPs. That's why. So 3 BP is offered in good risk only.
After the chemotherapy, then I will subsequently again do CT scan to assess for the CT scan and tumor markers to assess for whether there is regression of the disease or not, and then further plan treatment accordingly.
So at what step? Okay, it's already orchidectomy. So if it's a de novo case, that orchidectomy has not been done before, and the values are same, the markers are same, then how will you plan the case?
Sir, if orchidectomy has not been done before and markers and the imaging is the same, then I would initially go for a high inguinal orchidectomy to confirm my diagnosis and then further plan the chemotherapy.
Is there any scenario in which you can postpone the orchidectomy and go for the treatment?
Yes, sir. In cases where there is extensive metastasis with very high tumor markers, especially if beta HCG is more than 5,000 and the patient is symptomatic, with say extensive pulmonary meds with respiratory distress, then we would initially, for stabilizing the patient, give 1 to 2 cycles of chemotherapy. After that, we would do subsequently orchidectomy. In between
So
the...
will you require a biopsy report in that scenario?
No, sir, because the tumor markers would be suggestive, and tumor markers and imaging would be suggestive.
Will you do hemiasterectomy on him or not? Any point of time?
Sir, since the patient does not have any clinically, the patient does not have any nodules, the scar is healed, there is no palpable nodules in the right scrotum, and also on PET CT scan there is take, would only do a scar excision.
When?
Beg your pardon, sir?
When will you do this? Before chemo, after chemo, or
After completion of the chemo.
okay?
So do you consider that that site will resolve with chemotherapy, or
Sir.
there will be a residual tumor till after completion of the chemotherapy?
Sir,
What is the response rate in that scar or the spermatic cord post chemotherapy? What are the chances of response?
So, I don't know the exact figures, answers to the question, but I reviewed literature in that it was in scar recurrences, most of them resolved post chemotherapy, and you need not do actual surgery, or if actual surgery is required, only scar excision is sufficient.
And how does the scrotal violation affect the prognosis?
So I couldn't
Does
hear.
it have any effect on prognosis or not? Apart from the higher chances in the inguinal road region?
No, sir, there is no change in prognosis, sir.
So how many cycles he received chemotherapy, and what chemotherapy he received?
Sir, he is receiving 3 cycles of. Sorry, he is receiving 4 cycles of BEP, sir.
He is receiving.
Yes, sir. He yet has to complete treatment.
So next we have to ask you hypothetically what will happen, or you will show his response or something.
I think hypothetically, sir.
Yeah.
His best we
How
can
do you
complete
use
the
the
scenario
biopsy in this patient?
that way.
Beg your pardon, sir?
How do you give the bleomycin in this patient?
How do we give? We give it we give it 30 units on day 1, 8, and 15, or day 2, 9, and 16 of each cycle. We give it as a bolus dose.
Okay, so what parameters do you observe or not observe with respect to bleomycin, apart from
Sir,
respiratory function? Do you require blood investigations or not?
Yes, sir, we require blood investigation, sir,
For
before
bleomycin?
chemo.
Before chemotherapy, every 3 weeks you require investigation. For bleomycin
Yes,
specifically, you require hemogram every week?
No, sir. I don't know, sir. I'm sorry, sir.
Okay. It's a very less hematotoxic.
So do you give chemotherapy in your place, Mandar?
Yes, sir.
You guys gave chemotherapy.
Yes.
That's fine. Then I think Ashish's question is valid.
So what's the maximum tolerated dose for bleomycin?
360 milligrams. Sorry, 360 international.
It's 300 units. You give 10 doses. You give 10 doses of bleomycin in total?
No, sir.
Okay, proceed. Let's see that. So, how will you?
So we'll have to consider
now?
what will you do post completing for BP?
Post completing BEP, I would again do imaging of the patient. That is CT. Since he's not, I will do a CT whole abdomen and CT thorax, abdomen, and pelvis, and also tumor markers. This, sir, this I will do after 1 month,
okay.
at least, and I will assess whether the tumor has size has decreased or not. if the tumor size has decreased to less than if the retroperitoneal lymphadenopathy has resolved to less than 1 centimeter, and if tumor markers are normal, then I would observe the patient.
Okay.
Okay, Mandar, there are two things here. Once you have done PET CT or there was nothing in the chest, so in follow-up you will still do the CT chest?
No, sir. X-ray and
X-ray, I think, will be suffice unless we
Yes.
expose it to the radiation. And tumor markers anyway you have done. And I will just ask you a difficult question. Maybe you may not be knowing. There is a center, there is a surgeon, rather, there is a center in the world who does RPL&D in such cases where you said there is less than 1 lymph node and tumor markers normal in NSG-CT. And they say that it is around 20% of these patients will have the disease. Which place is this?
sir, Indiana Medical College, USA.
No. There is a MSKCC, George Shenfield does, but rest of the world doesn't agree. If you go to any conference, talk to this. I think there is no node on CT scan and tumor markers are normal. This patient probably will be for follow-up in most of these places. Okay, go ahead. Next scenario.
Sir, if the size of the retroperitoneal node is more than 1 centimeters, tumor markers are.
So if you have a retroperitoneal mass residual which is 4 centimeters, which is as you showed the initial picture, it was on the right side, right, affecting, or it is in very closely abutting the right renal vein, and there is a 2.5 centimeter right external iliac related mass remaining.
Yes.
What will you do?
Yes.
Tumor markers are normal. So before you do the surgery, just let us know how will you assess the patient for surgery otherwise. You have given some cycles of BEP and everything.
Yes, sir. So I would do his pulmonary function test, in
Okay.
which I would assess for by DLCO and by spirometry.
PFT DLCO you will do, and you will see if the tolerance is good, PFTs are normal. And
Yes. And his basic investigations for surgery, pre-anesthetic checkup.
okay. So this mass is almost stuck to the right renal vein. How will you counsel the patient?
I will counsel the patient that during the surgery the patient may have vascular injury which may require vascular reconstruction, and post-operatively the patient may develop right lower limb venous thrombosis, and also there are chances that there would be compromise to the blood supply of the right lower limb.
Why venous thrombosis?
Foresee the venous thrombosis per se in this case.
I mean, you said that there is a likelihood of injury to the right renal vein. Okay, agreed. If I say it is moreover stuck, but whatever.
Right renal.
So you can reconstruct that, but I didn't understand the venous thrombosis and the edema.
Adherent nodal masses in the right iliac region, sir. So while removing that, if there is any vascular injury, we may require reconstruction, and that may lead to.
Practically, that doesn't happen, Mandar.
Yeah. So,
The nodes are easily.
You want to still counsel the patient like that? We have no problem. Okay. So anything you would counsel such a patient about the post-op phase?
Post-operatively, I would tell that the patient may have complaints.
So pre-operatively, even if I am in your place, I'll also counsel the patient about a good lung exercise. I would probably send the patient to a lung clinic because he doesn't have lung metastasis, but he does have a bleomycin given.
Yes, sir.
Okay, you continue with post-op.
Just before going to post-op, can I ask you this question? Suppose he doesn't respond at all. There's the node, probably they have increased in the size, and still the tumor markers are normal. So what will you do?
The node has increased in size, but the tumor markers have receded.
Sometimes hemorrhages occur, they do increase in the size. You once in a while see this situation, and tumor markers are normal. What will you do?
I would go in for retroperitoneal lymph node dissection.
Okay,
Because
good.
this happen in two scenarios. One is as the hemorrhage, as you stated, and the other is in cases where there is residual teratoma. Because teratoma will grow in size, but the tumor markers will be normal, and the treatment is surgical. It does not respond to chemotherapy.
So that actually brings to my first question. Suppose he is stage 1, like there is no node, maybe 1 or 2 centimeter lymph node, not such a big lymph node, and primary is teratoma. What will you offer this patient? Chemo or lymph node are not 2 centimeter, suppose 2, 3 centimeter, 4 centimeter. What will you offer this patient with the primary
Peritoneal lymph node dissection.
Yes, the patient has to go for RPLND. Why?
Sir, because teratoma does not respond to chemotherapy, and it grows in size and has also chances of secondary somatic malignancies. So the treatment is surgical.
What type of malignancy and how much time does it take to occur?
Okay.
Sir, teratomas can differentiate into adenocarcinomas and sarcomas. Sir, I'm not aware of the time.
What sarcoma? What sarcoma? It's rhabdomyosarcoma.
Rhabdomyosarcoma. Yeah. So they can differentiate into rhabdomyosarcomas.
And there is another question. Do you think there is role of primary RPLND? Suppose this patient is, not such a big tumor, is NSGCT. Is there any role of primary RPLND? Like a stage 1, you say, how do you manage stage 1?
Sir, in non-seminomatous germ cell tumor, 3 options are available. One is surveillance, one is single dose chemotherapy, and one is primary RPLND.
So sir has asked you a question.
It is 2 dose.
Consider RPLND in stage 1 and stage, say, 2A, and give your opinion on that. Will you advise, not advise?
Primary RPLND in stage 1, stage 2A.
See, say high risk PS1 in NSGCT, okay? Pathological stage 1 in NSGCT, high risk. So you will want some adjuvant therapy.
Yes, sir. I would go for chemotherapy and then assess. And if it is not responding, then I would do a post-chemotherapy RPLND in high-risk cases.
Why not primary RPLND?
Because in high-risk cases, there are chances of systemic, already systemic metastasis. So primary chemotherapy would help better rather than upfront RPLND.
So you mean 100% of the patient will be having micrometastasis in high risk? How many percentage of the patient will have micrometastasis if you do RPLND in 100? So how much will not be having? Will be saved from chemo?
Sir, in primary RPLND,
okay, that's fine. Almost 30%, 25 to 30% of these patients, when you offer primary RPLND to stage 1 tumor, you can save them from chemo. Okay.
Yes.
And one situation which I told you, the teratoma in primary with the lymph node in retroperitoneum, they have to have RPLND, no chemo to them. And when you give chemo to stage 1 or 2A, it's I think 2 cycles, if I'm not wrong, of BEP or EP.
Yes.
EP 3 cycles. Single dose carboplatin, the dose for stage 1 seminoma.
Seminoma.
So when you do RPLND, have you seen RPLND?
Suppose if it is a
can I ask you any question on RPLND?
Sir?
Mandar?
Yes, sir.
Can I ask you a question on RPLND per se?
Yes, sir.
Okay. So when you do RPLND, what is in your mind? When you know the anatomy of retroperitoneum, isn't it?
Yes, sir.
What are there? What are the things there?
Principles of RPLND is that we have to, in case of primary RPLND, we have to do a template dissection with dealing of the landing sites. In case of post chemotherapy RPLND, we have to do a bilateral template dissection. And the next thing that we have to remember is that we have to try to do a nerve sparing RPLND so as to prevent retrograde ejaculation. And to do that, we have to identify the. We have to do a technique known as split and roll technique, and we have to identify and clip or ligate the lumbar veins, lumbar vessels. The reason for it is that the lumbar
Lumbar
vessels
vessel.
to. Sir?
Yeah,
The
go ahead. Go ahead.
lumbar vessels will guide us to the nerves to be spared, and the other thing is that we will also be clipping and using clips and ligation so as to prevent subsequent chyle leakage.
Okay.
So chyle leak is important, and when you approach which side, it's in the suprarenal part, the chances of chyle is important, or in the infrarenal part is more important?
Suprarenal part.
Yeah, chyle fistulas and chyle usually occur when you approach the suprarenal part.
Yes.
Okay. So, what advice will you give to your anesthetist?
Sir, the advice that I will give to the anesthetist is that since the patient has already received 4 cycles of bleomycin, the patient will be having compromised lung function. So the FiO2 has to be kept low. That is, it has to be kept 50 to 60%, and the patient has to have adequate hydration.
And another point is that the CVP should be low when you are dissecting on the vein.
Yes.
Okay.
So another thing which I would like just to say is retrocrural lymph nodes in testicular tumor. They also can occur, and if post chemo they are there, you have to do the retrocrural lymph node dissection. Suprahilar dissection also be done when the nodes are there. Not that you always do infrahilar. If the nodes are there, then you do the suprahilar dissection. Just to tell you, because I don't expect, but that's good that you made a good point in technique, at least at your age. So next.
So Mandar, if this would have been sir, I'm taking it to a seminoma. If it was an advanced seminoma, okay, how would you have managed it? Say it was the intermediate risk IG, CCG, seminoma. We have done the right high inguinal orchidectomy, and there is this big mass. So you gave 4 BPs, and you have a residual mass which is say 4 centimeters. Now how will you manage it?
Sir, if the residual
tumor markers normal,
have got a tumor markers are raised, normalized. Sir?
Normal.
Normal, usually in cinema, they're normal.
I would like to, since I already had a pre-treatment PET CT scan, I would do a PET after the completion of the chemotherapy. After 4 weeks, 4 to 6 weeks, I would do again a PET, whole body PET CT scan to assess whether there is any residual disease present in that 4 centimeter nodal mass, and if it is
so if I have done a CT scan almost say immediately in for first 5 days after I finished the last dose chemotherapy, and I have 4 centimeter mass, we will repeat a FDG PET CT at 6 weeks, so that we will also see a continuing, maybe a reduction. It may go below 3 centimeters or it may remain at 3 centimeters. So what will you do if it is more than 4 centimeters at that time?
Sir, if it is more than 4 centimeters at that time and with evidence of FDG uptake, which suggests that there is residual tumor, then I would go in for retroperitoneal lymph node dissection. Okay. So CT says that the mass is very plaquey. It is 4 centimeters. It is 4 centimeters kind of vertical. 4 centimeters by 1 centimeter by 1 centimeter. It is an absolutely plaquey fixed mass, and it almost rotates around the aorta 235 degrees. Sir, I would like to observe the patient because many a times this mass may decrease in size, and also there are. But we have observed for a long time. 6 weeks is kind of the PET CT should show us. I mean, that's the ideal time. Then I would go in for second line chemotherapy. Okay. If there is FDG take value. Okay.
Any other option?
Zoom meeting.
So conventionally, this treatment which I would do surgery.
Silence la
somebody is talking in between. So conventionally, the treatment above 3 centimeters residual was surgery. After PET, we see that more than 3 centimeters, whether they are showing FDG expression or not showing FDG expression. Suppose if they are not showing FDG expression, what will you do?
They are not showing FDG expression.
So you will observe probably.
Observe.
So if they are showing FDG expression, our conventional thing again holds true, we'll do surgery. Now it depends on the assessment, how difficult is going to be the surgery. If this tumor is globular round, also had some nice globular tissue, it is easy for surgery. But if it is absolutely plaquey and encasing the aorta, sometimes the surgery becomes damn difficult. There is no absolute guideline, but sometimes you can do a biopsy and check. If you are still it's a difficult surgery, then you can consider something like radiation.
Yeah. Before actually, since the seminoma is going on and our PLND part has been summed up very well by Ganesh. And so, can I ask you one question? If suppose patient is coming of testicular tumor to you, you did high orchiectomy, but before doing high orchiectomy, his AFP was 100, and the biopsy comes as seminoma. How will you treat him?
I will, if the FP was 100, then and biopsy comes as seminoma, then I will investigate the patient to see if he has got any liver pathology which has which is contributory to the high AFP, and I would also like to repeat the AFP value after 4 weeks, after 2 weeks at least.
After
And review the
2 weeks
biopsy
of
too.
orchiectomy, it is still 100 or 50, whatever it is not come down.
Sir,
See, AFP is a very specific for NSGCT. If
yes,
AFP is high any value, you cannot treat the patient as seminoma. He
yes,
has to be treated as mixed germ cell tumor.
yes, sir.
Okay. Then another scene is you have done like 3B. You treated this patient, so 3B. He got residual masses. Now his tumor markers beta HCG and LDH are normal, and AFP is 10. Then what will you do? You do see these pictures. I probably may be wrong in telling you, but I'm just telling because we
we see
these
such
things.
kind of pictures, and
yeah.
So sometimes AFP remains elevated. I gave you the answer partly. So many times we still observe these patients because there is no documented disease anywhere, and some people stay stable with a slightly elevated AFPs. This is what we have seen.
Yeah, up to 20 AFP, you can actually go ahead as a negative, provided, as you said, this may be liver disease or something is there. So you it has to be actually done again and again. It's not that it is rising and it goes to 100. No. So there's these are the things. So
Sir,
we can go for
yes, sir. They are saying to wrap up the case discussion.
Yeah, yes, it's time actually. A lot of time.
So Mandar, you stop sharing. I'll share and do the presentation.
Yes, sir.
So this presentation is an overview of.
Sir, before you start, while you load up your screen, sir, thank you, Dr. Manda, for the presentation. Can we have any comments for him from Dr. Sudhir, sir, Ashish, sir, and then Ganesh, sir?
No, he's done very well. I think we are hardcore urologists, me and Ganesh, but he actually answered most of the question very well.
Yeah.
Few of them I don't expect from him. It's just for teaching other guys also. So that's a good. He's quite well informed, and I think he is reading for your exam going, na, Mandar? Yeah.
Yes.
So all the best.
Thank you, sir.
Keep it up.
Yeah.
Well done, Mandar.
Thank you, sir.
Yeah, I think Mandar, you did very well. I think the histories and the choice of investigations was quite perfect. As a protocol and as per the sensitivity, we also do the CT chest in the beginning as well as in follow-up every time, honestly. So I'll start this presentation. It's an overview.
Yeah, sir, we request Ashish sir and Sudhir sir to stay till the end because after your talk, we'll have a Q&A with the examiners.
Okay.
Please, sir, you can please go ahead. You have our full attention.
Contemporary management and controversies. So I've taken few controversies in the end. Just a minute, slide. Okay, so briefly, the WHO this is how testicular tumors are classified. A is we have GCTs from germ cell, GCNIS, which are the usual ones we see. Then GCTs unrelated, spermatocytic tumor, teratoma, yolk sac, and mixed, sex cord tumors, and the miscellaneous one. So how we investigate a testicular mass, as was mentioned in the case, ultrasound is a very nice investigation, nearly 100% to pick up a lesion. Typical, it is hypoechoic, sometimes heteroechoic. Microlithiasis can be there, I have discussed it further, and we can find burned out primary testicular tumors with a good ultrasound. So no tumor on USG, we can have suspicion of a primary extragonadal GCT. And important thing is to document about the opposite testis. That is important. Next important thing, tumor markers. As we all discussed, AFP, 5 to 7 days half-life, beta HCG, 24 to 36 hours. LDH is pretty non-specific, but used still in the seminomas. And as we were discussing, LDH sometimes also can remain a little high after the NSGCTs remain to come back to normal. Tumor markers should be obtained prior to orchidectomy and post-orchidectomy. Post-orchidectomy marker levels are used in staging. For rare patients with advanced disease who need urgent treatment, substantially elevated AFP beta HCG can be considered sufficient for diagnosis of GCT. So we proceed with treatment, which may be chemotherapy directly in these patients, not waiting for any kind of histopathology. And in pure teratomas, Dr. Sudhir sir was asking this question, markers may not be raised, so they can be absolutely normal. There will be a retroperitoneal mass sometimes with normal markers. So more markers, microRNAs are emerging, the new potential biomarkers. Preliminary evidence suggests a higher discriminatory accuracy for miRNAs compared to conventional markers. And obviously there will be lab issues and all before we absolutely start using them. So the first test again and the surgery, high inguinal orchidectomy. Many times we all get patients with a scrotal orchidectomy, which is not so desirable. HIO involves removal of testis cord till the level of internal link. Transscrotal is contraindicated. It leaves inguinal lymphatics intact and increases chance of local recurrence. There can be 2 to 10% nodal presence there later on. So avoid delay of more than a week for diagnosis. We want to proceed with the surgery fast. The report of histology should have histologic type, size, multifocality, local tumor invasion, which we require in the staging. Presence of GCNIS, LVI. LVI is a high-risk indicator, margin status, and relative proportion. We all know this, inguinal incision may extend as a hockey stick if there is a huge tumor. I am not going to talk the steps of the surgery. So about imaging, we do a CT chest, abdomen, pelvis, provides information about the N and the M staging. The retroperitoneum is the initial site of spread for 70 to 80% of the GCTs. Some can skip. Choriocarcinoma has highest hematogenous spread, lung, liver, bone. Bone is still rarer in GCTs. Landing zones for the right, interaortic cable, lymph node followed by paracaval, paraortic, left, paraortic followed by interaortic cable. Spread from right to left more common than left to right. These are mostly as per the mapping studies of lymphatics. Lymphatics then drain into the cisterna chyli, retrocrural, thoracic duct, posterior mediastinum, and left supraclavicular fossa. So more caudal deposits indicate retrograde spread to the iliac and inguinal, as we discussed, and more common in patients with also history of inguinal or pelvic surgery. So prior pelvic surgery may also change it. Something like orchidopexy may slightly change the lymphatics. Imaging for staging. No consensus for size criteria for the node. 1 centimeter is mostly used. Nodes 5 to 9 millimeter in the primary landing zone, however, should be viewed with suspicion and caution. They can be positive. Sensitivity 67%, specificity 92%, and CT brain in some patients of NSGCT with multiple lung mets, or if we have a HCG values more than 50,000, that means we have a choriocarcinoma where we have extremely high HCG values. We have seen values from 5 lakh to 17 lakhs, and then MRI brain can be done. GCTs grow very rapidly, so management decisions should be done on the imaging which is recent. What about MRI? MRI can be done for the scrotum, abdomen. It is more better than the sonography for the scrotum. MRI brain in cases with choreo. FDG PET CT, there is no role in initial staging. It's there in most of the guidelines. It is done in the evaluation of post-chemotherapy residual masses in seminomas. one take on fertility issues. Now, we had a case where the patient was married and had 2 children, but most of the patients are young and would desire to have a family later on. So, and important medico-legally, document semen parameters before starting treatment, many times prior to HIO. In case advanced disease, sperm cryopreservation should be done at least prior to starting the chemotherapy, if not done prior to HIO. Prior to HIO, the meaning is that there might be some sperms coming out of that testis also, and in general there might be some depression of spermatogenesis after the surgery of HIO. So prior to HIO, assisted ARTs can be used if cryopreservation was not done for fertility, and there are many ways where andrologist, urologist can help you out. So if not cryopreserved, fertility usually returns 1 year after that one cycle BEP in a stage 1 NSGCT, or 3 to 4 years after 4 cycles of BEP. So tumor markers important, semen analysis important in unmarried, and to document imaging is sonography, CT, thorax, abdomen, pelvis, sometimes CT brain, the pathology of the hyenguinal orchidectomy. So staging testicular cancer, these are standard slides. Primary about the primary tumor, T0, TIS, carcinoma in situ. T1 is limited to testis and epididymis without vascular lymphatic invasion, but tumor may invade tunica albuginea, not the vaginalis. T2 is with tunica vaginalis and also with vascular or lymphatic invasion. T3 is invading spermatic cord. T4, as you all know, is scrotum. So N0, N1 is nodal mass 2 centimeters or less, or multiple nodes, none more than 2 centimeters. N2, nodal mass more than 2 centimeters, but not more than 5, or more than 5 positive nodes, none more than 5 centimeters, or evidence of external extension of tumor. N3, metastasis of node mass more than 5 centimeter in greatest dimension. M1A, non-regional nodes or lung metastasis. M1B, distant mets other than non-regional nodes or lung. So liver goes in M1B. Bone, if rare, can go in M1B. S1, S2, S3. About LDH, it is less than 1.5 times normal, 1.5 to 10, and more than 10 times normal. HCG, less than 5,000, 5 to 50, more than 50. Very easy to remember. 1,000, 1,000 to 10,000, and more than 10,000 for the AFP. So stage 1A, B, 1S is a peculiar stage. We'll come to the management later. Stage 2A and B, again important. 2C to 3, all stages go in the advanced. 2C to 3A, 3B, 3C. International Germ Cell Cancer Collaborative Group risk stratification classification for advanced germ cell tumors. So for the seminoma, it is only good and intermediate risk. Seminoma intermediate risk is having non-pulmonary visceral mets. That's the difference. IG, CCCG for the NSGCT, basically good, intermediate, poor as per S1, S2, S3. And in the poor, it can be primary site of mediastinum and metastasis of non-pulmonary visceral metastasis. So that is how you go for good, intermediate, poor. Points to remember again: proper clinical staging, post-HIO markers, then at a certain time, complete the staging in advanced GCTs, the classification of IG, CCCG. Treatment decisions are always secondary to this staging. So what we get finally is a right or left testicular or primary retroperitoneal or primary mediastinal seminoma NSGCT with the TNM stage and IG, CCG risk stratification for advanced tumors. Coming to management principles, young age and good ECOG permits aggressive management, possibly of cure even on the presence of metastasis. Chemo is administered regardless of TLC platelet count and even in presence of moderate renal insufficiency. Aggressive surgical approach to resect all residual disease after chemo, because probably this is the most successful story in metastatic cancer. Diagnosed on testicular biopsy, done for infertility, contralateral testicular biopsy, the management of GCNIS or contralateral testicular biopsy or during testis preserving surgery. Rationale for treatment: 50% risk of invasive GCTs at 5 years. HIO is the definitive treatment, but 20 gray of radiation has similar control. However, scatter from RT may hamper the other testis. you should remember that chemotherapy is less effective in GCNIS. GCNIS in solitary testis can be observed versus early radiation. So coming to stage 1 seminoma, 10 to 15% with stage 1 seminoma have occult metastasis. The treatment options include surveillance, adjuvant, RT versus chemo. Decision is based on patient's risk factors, which are tumor size and invasion of rete testis. The surveillance option, only 10% have occult met, so RFS is 85% at 10 years. Hence, the surveillance option with no high-risk features, the recurrence rate drops to 6%. Cancer-specific survival, 99%. Advantages has no toxicity of radiation or chemo. Disadvantages, repeated CT scans, radiation exposure, and a cost. So, and patient should be absolutely compliant with a strict follow-up. About chemotherapy for stage 1 seminoma, it's single agent carboplatin. Nowadays, many times one cycle is given with the dose. 5-year DFS is 96%, and follow-up annual CECT abdomen pelvis. So ongoing trial with one cycle of carboplatin, one fraction is also going on, and it's quite successful versus 1 BP. Radiotherapy for stage 1 seminoma. Earlier, 20 to 24 grays of dogleg configuration used to be given. There would be toxicity of grade 2 or 4 GI, persistent oligospermia, and a chance of secondary malignancies, 18% at 25 years, 2 to 2.6% risk of death from SMNs at 15 years. And currently, radiation only to the retroperitoneum, about 20 grays is. If you see the 2021 guidelines, one course of AUC7 carboplatin chemotherapy is considered very strongly today. And if you see the last line, adjuvant radiation therapy should be reserved only for high selected patients, not suitable for surveillance and with contraindication for chemotherapy. So here chemotherapy has taken a front seat. About stage 2AB seminomas, if you see treatment, it is in 2A radiotherapy or chemotherapy 3 BPs or 4 EPs, and in 2B the same treatment, but if you're opting for radiotherapy, we give a boost of 2 grays into 3 to 6 grays for the lymph nodes. So follow-up protocol at CT 3 months, 6 months and 12 months, and then annually till 5 years. Advanced seminoma 2C, 2-3, stage 3 seminomas, good risk or intermediate risk. As we discussed, no poor risk. What happens is good risk has a 3-year PFS of 93%. Response assessment is usually done 6 weeks after completion of chemotherapy and an FDG PET. We discuss these further managements of residual nodal masses less than 3 centimeters and more than 3 centimeters. In short, this is the BEP regimen. So the bleomycin, I'll read 30 milligrams day 1, 8 and 15, cycle repeated every 21 days. The summary of seminoma management. So if you see the stage CS 2C to 3, good risk and intermediate risk, we use almost BP 3 and 4. In the NSGCT stage 1, occult metastasis can be present in 25 to 30%. The high risk features which are important are LVI, predominance of embryonal component more than 40%, and MIB1 staining more than 70%. Again, options available: surveillance for the non-high risk or adjuvant chemotherapy and RPLNT. Here, radiation therapy is not a choice. Surveillance for stage 1 NSGCT, 70 to 80% may not have any occult mets, and those who relapse on surveillance almost always salvaged with chemotherapy. Disadvantages: relapse rate of 40% is high, if 15% if low risk at 5 years. So if high risk features are there is a 5-year relapse rate of 40%. Cost and radiation and compliance. These are most important things in surveillance protocol here. About adjuvant chemotherapy, single cycle of BEP today is given, relapse-free rate of more than 95%. So it is absolutely effective. One cycle BEP has shown to be as effective as 2 BEPs. It is a non-significant non-inferiority difference. RCT compared, 1 BEP versus RPLNT also, RFS is better with BEP. So this is about primary RPLNT versus 1 BEP. No significant long-term toxicity, preferred treatment option in clinical stage 1 NSGCT with high-risk features. RPLNT again for stage 1 NSGCT, nerve sparing at centers of excellence has been described. However, relapse rate is around 10% at 5 years, and patients then need 3 to 4 cycles of BEP. Further management according to the histopathology. RPLNT may be preferred over chemotherapy if the HIV specimen had teratomatous component predominantly with LVI. So offer surveillance or risk-adapted strategy in patients with stage 1 NSGCT selected, and discuss one BEP as a treatment alternative in patient not actually willing to undergo comply with surveillance. Stage 1S, that's a special stage where repeat tumor markers and CT scan and USG of the other test is to confirm that no macroscopic disease is being missed. What happens in stage 1S is the tumor markers remain persistently high even after the high inguinal orchidectomy, and the treatment goes with BEP 3 cycles or EP with 4 cycles. For the stage 2A with S0, we can observe and repeat imaging again after 4-6 weeks if stable disease, nurse sparing RPLND, if regression, surveillance. With 2B, S0, nurse sparing RPLND is the preferred treatment. About 80% of patients actually can be avoid chemotherapy with this kind of protocol. So further management after primary, this is what I already discussed in the last slide. Stage 2C and stage 3 NSGCT, which are the advanced NSGCTs. So good risk, BEP into 3 cycles, intermediate and poor risk, either BEP into 4 cycles. BEP into 3 has an option of 4 EPs, and BEP into 4 has an option of VEIP, ifosfamide and cisplatin. Response assessment is initially by tumor markers after 1 or 2 cycles also, so that if there is any progression, we can change the line of chemotherapy. Final assessment by tumor markers and CT scan 4 to 6 weeks after the last dose. So 4 to 6 weeks will give us a complete idea of resolution, maximum resolution or residual. And these are again the chemotherapy schedules. So what about NSGCT post-chemotherapy residual masses? Necrosis 40%, usually teratoma 45%, and viable malignancy seen in about 15%. FDG PET is not recommended here, especially teratomas are not FDG avid. RPLND is mandatory in all residual lesions more than 1 centimeter. Outcome of teratoma depends on completeness of the resection, as they are not chemosensitive. So you should do the best possible surgery you can do. 6 to 8% of PCS post-chemo specimens contain non-GCT malignancies arising from malignant transformation of teratoma, most commonly RMS. Patients with necrosis only have a favorable prognosis. So post-chemo status, what we use the terminology is complete remission, that is normalization of serum tumor markers, RPLND, and resolution of the radiographic disease. So RPLND is not indicated. Masses less than 1 centimeter, role of RPLND is uncertain, but guidelines say less than 1 centimeter, we don't do an RPLND. 6 to 9% still have a chance of recurrence with observation protocol. This was mentioned by Sudhir Rawal sir during the case discussion. And RPLND is about salvage chemotherapy. RPLND is recommended even remaining after salvage chemotherapy. So that is a separate sentence you should remember. Residual mass more than 1 centimeter, as we discussed, RPLND is mandatory. So residual masses in different locations. 1/3 patients have residual masses at multiple sites: retroperitoneum, chest, left supraclavicular fossa. We perform infradiaphragmatic and supradiaphragmatic resections in separate stages. There can be concordance or discordance. So discordant histology can be there 20 to 40%. There is also good concordance between retroperitoneum and the lung lesions, about 70 to 80%. Presence of necrosis in RPLND specimen is highly predictive of necrosis at other sites, and that's about the concordance and to operate. If the sites in lung are very difficult to operate, then we can just believe the concordance and follow up the patient sometimes. About RPLND in short, there are 4 categories: primary RPLND in early stage, stage 1 or stage 2A, B, post-chemo, that is after induction chemotherapy, salvage post-chemo RPLND after induction and salvage chemotherapy when there is a residual mass with normal markers, and a desperation post-chemo RPLND where despite multiple lines of chemotherapy, the tumor markers remain high as well as the mass remains. So preoperatively check markers in the last week before surgery, no bowel preparation, check lung functions since bleomycin is used, and pre-op imaging should not be more than 6 weeks old. So there are various templates. This is the complete template, infra-hilar bilateral template. The lateral margins are both the ureters. Lower ends are the crossing of the ureters on the common iliac. We don't go on the hypogastric here. And the renals are the upper margin. So we remove everything within this area. These are the templates for the left and right. So the intent is to leave behind the nerves and spare an area where we can, it's specially used in primary RPLND for stage 1 and 2 disease, or in post-chemo RPLND only if the residual mass is less than 5 centimeters and the patient is not in the poor risk category. So if it doesn't fit this criteria, then we don't go for it. Sparing RPLND, we can make an effort and do the dissection like this. Aim is to preserve the L1 to L3 postganglionic sympathetic nerve fibers and the sympathetic chains to preserve antegrade ejaculation. So as you remove the tissue, these kind of nerves should be left behind. Bilateral nerve sparing RPLND has been the standard option as much possible and feasible. Even post chemotherapy, it should be used as much as possible. Ipsilateral template resection with contralateral preservation of nerves in selected patients has been reported to yield equivalent long-term results comparable to bilateral systematic resections as far as the cancer-specific survival goes. What about extraperitoneal RPLND? This is a paper published about extraperitoneal RPLND. And what it basically concludes is we have to select the patients well. It is safe and oncologically complete with lesser morbidity. Probably the side effect profile and the complications profile is slightly low. Median time of return of bowel is 2 days. Hospital stay, this is a Western stay, but our patients also can remain for a slightly lesser duration of days. So consolidative chemotherapy after RPLND, after resection, if there is necrosis or teratoma, no further treatment is required. 2 cycles of TIP or VIP when HPR shows a viable tumor. So follow-up after post-chemo RPLND, this is a follow-up protocol, year 1, 2, 3, 4, 5. So imagings, first year 6 months, second year 6 to 12 months, and later on annually in the third year. RPLND, few things about RPLND everybody should remember. Best done at a high volume center with an experienced surgeon. Approach of the surgery can be big with the experience and comfort of the surgeon and as per the size of the lesion and the complexity. It can be open, lap, robotic. Coming to controversies, this is not a controversy, but testis sparing surgery. So no role in patients with contralateral testis. Indications, synchronous metachronous tumor or tumor in a solitary testis. The third would be in pediatric patients. Aim, preservation of hormonal and fertility function, performed only if the tumor is less than 30% of the entire testis volume and if the testosterone levels are normal. Intra frozen section is mandatory and has a high concordance with the final histopathology. When to do biopsy of the contralateral, 5 to 10% of the opposite testis would have GC NIS. Consider opposite testis inguinal biopsy in atrophic testis, which the size is less than 12 ml. There is a history of cryptorchidism, age less than 40, and poor spermatogenesis. About microlithiasis, these are the sonography pictures defined as innumerable tiny bright echoes diffusely and uniformly scattered throughout in the substance of the testis. Microlithiasis has been associated with testicular cancer. However, it is significant only in scenarios and only these patients need to be kept on surveillance. So those who have previous germ cell tumors, history of orchidopexy, atrophy volume less than 12 ml, and history of GCT in the first degree relative. So that microtesticular, if we have a case, we should relate to these 4-5 things and then think about it. Fertility issues we did discuss, but most of these patients are young. Sperm cryopreservation is recommended prior to chemotherapy. At least assisted reproductive techniques can be used, and there are a lot of ways where the sperms can be got out from the testis. Growing teratoma syndrome, incidence is less than 5%, but it refers to the progression of disease burden in the absence of elevated markers. Mature teratoma is chemo and radio resistant. The only treatment is surgical option. Extraconadal GCTs. Primary retroperitoneal GCT has the same prognosis as the testicular germ cell tumor. Primary mediastinal GCT, however, indicates poor prognosis. Therapy options remain absolutely the same as for an advanced testicular germ cell tumor. In an undescended testis, management options remain the same. It does not indicate actually a poorer prognosis. We have 2 options in undescended testis. Either you go in, remove the testis, get its histopathology, and as per the stage of the disease later on, give chemo, SOS, do the RPLND, or in some cases, we do a biopsy, we get the histopathology, correlate the tumor markers prior. We check if it would be an NSGCT and then give chemotherapy and see the residual and operate everything remaining at the end of the treatment. About scrotal violation, we know why it happens. Scrotal violation, it leads basically to alteration of lymphatic drainage. Inguinal and pelvic nodal disease can be there. These nodal basins are non-regional for the CA testis. However, scrotal violation without positive margins does not adversely affect relapse and survival. Role of cord revision and scrotal scar revision is not very well defined. Why this sentence is here? Because many patients who have received chemotherapy already and scrotal scar revision done, nothing has been mostly found. So upfront chemotherapy, usually the line of management is HIO, HPR diagnosis, repeat markers, and then chemotherapy for advanced disease. However, some patients may have high disease burden and may be very symptomatic. Patients can come breathless, patients can sometimes come with hematemesis and lot of bizarre presentations. So in these cases, upfront chemotherapy can be started without performing HIO to achieve a rapid disease control. And what probably I would do is I would document with a sonography the side of the testis, so that later on post chemotherapy, even if both the testes become absolutely normal, it would be better to do that HIO after at the time of RPLND whenever required. Thank you. So this was a overview.
Thank you, Ganesh sir. That was comprehensive. The topic has been covered, and actually a lot of questions on our Q&A you have already covered in your talk, sir. But as the participants have put this, if you don't mind, can we go through these questions, sir?
No, absolutely. We should go through these questions.
Thank you, sir. So I have given the questions. I've directed them to the examiners. However, other examiners are also welcome to contribute. The first
How
question
do you sequence surgeries when residual disease present in both UL is
unilateral, I think, sir.
Okay, unilateral thorax and retroperitoneum. So what we do is, obviously post chemotherapy, one important thing is discussions in the MDTs, and then we usually do the retroperitoneum first. Sometimes if there is a very low burden in the thorax, we can even under thoracic surgeries, I mean the lung lesions are peripheral, you can do it with the same time. You can do a VATS up and an open procedure or whatever down. And if the lung nodules are multiple or they are at difficult sites, then we would stage the procedure. We would try to see the concordance of the histopathology.
Ashish sir and Dr. Sudhir sir, any comments, sir, on this question?
Very well agree with the. Basically, the retroperitoneum is the first echelon area to be effective, and the finding in the retroperitoneum suggests most of the time the finding in the thorax. So the retroperitoneum is suggestive of fibrosis. Maybe for very small residual disease in the thorax, it may be negative most of the times. For a very large, more than 1 centimeter lesion in the thorax, one can go for surgery. But if the retroperitoneum is negative, the chances of fruitful surgery are less.
So we'll go to the second question.
Yeah.
Dr. Sudhir sir, sir, your indications for modified or unilateral template RPLD, sir?
No, I don't think I will do modified or unilateral template RPLND unless there is some anatomical problem, or maybe it is stuck so badly that removing one side of nodes, and which is actually does not happen if you operate these patients. It is not advisable to do unilateral template RPLND. If possible, always do the bilateral nerve sparing. You may have to take long time, but in the beginning of your career, suppose you have started, you can do these can offer this type of RPLND in the practice. But this actually is like in robotic. When I started robotic, even then we did both sides. But many people in the world, they started with modified RPLND with robotic. So preferably do bilateral modified, because RPLND there should not be a recurrence in the retroperitoneum. there are some data evolving as happened with all the robotic surgery that like in robotic cystectomy, people go for intracorporeal ileal conduit mostly rather than new bladder. Same way in RPLND, people are even talking about tumorectomy, but their data are not mature as of today. So when you see there's a lot of difficulty in removing tumor, technically difficulty I can say, otherwise I'll not offer modified or unilateral template RPLND.
Okay. Examiners, any other examiners inputs? So our next question, Ashish sir, the incidence of skip mediastinal and or supraclavicular lymph node mets. There were 2-3 times we got this question on the chat.
Yeah, theoretically there is a risk is there, but practically it's a very unlikely, less than I'm not aware of the exact percentage, but I think it's not more than 2 to 3% that without any retroperitoneal disease there is skip mediastinal node or a supraclavicular lymph node mets, although a theoretical possibility is always there. So we have seen such cases, very few, rare, but practical in terms, without retroperitoneal disease, the chances of skip mediastinal and supraclavicular lymph node mets are very less.
Our next question to Ganesh sir. Sir, are there any contemporary indications for Chevasu's maneuver?
Yeah, so I mean, once a year you will have a patient like that where you will see not a very characterized lesion on the sonography, maybe vaguely feel something. It's quite a rare situation with all these best imagings today. And that patient would be probably for a Chevasu's maneuver. Like you see some lesion on a sonography, the tumor markers are normal, patient is anxious, they will not leave you saying what it would be. They must be well read and would say that testicular biopsy should not be done. So then these few patients we can observe for a while. But if the lesions persist, then probably Chevasu's maneuver would give us the answer.
Incorporating frozen section if we have the facility.
The frozen section, absolutely. Or if you don't have a frozen section, then still you would have to counsel the patient, do a Chevasu's maneuver, wait for the actual histopathology report, because there can be places where there would be no frozen section facility available. So either refer there, or if we are doing, we'll have to. Again, what we do is after putting a vascular clamp, deliver the testes, bivalve the testes, take adequate number of biopsies from that area, which is kind of sonography marked. We can also avail the help of an intra-op sonography if required. So these are all the accessories which we should do.
Right. Our next question for Dr. Sudhir sir. Sir, should we be recommending testicular prosthesis in our patient?
Actually, always when you are doing this surgery, especially in young patient, you should discuss. I have done few of them when, especially one was doctor, and because especially NSGCT, they are sometime even less than 20 years. So if they want, you should always discuss and then give it. I'm not against it, because psychologically they feel better. So I always discuss with the young patients, especially if they are in 20s. Even the 30s, I will discuss with them, and it depends on their choice.
Next question for Dr. Ashish sir. It was discussed in the expert talk as well. Scrotal violation with stage 1 non-seminomatous versus seminoma. Would you be doing any additional treatments, including local scar excisions, plus minus ground?
We used to do that before, but with the current literature available, it's not required and does not benefit much. But if it is involved and is adherent, it's in duration, one can do a scar biopsy for eliciting if there is presence of disease in that or not. Otherwise, as such, if there is no any tumor in the scar is expected, then one can leave that area.
Yes, sir. And the indication for chemotherapy or surveillance will not change based on scrotal violation alone.
Yeah,
yes,
mostly. Unless until the tumor is involving the scrotum. Then for seminoma, the radiation field is to be redistributed.
Right, sir. Any other comments, Ganesh sir or Sudhir sir?
I think that's right, probably. Radiation would probably include that field. If we are giving, say, one for stage 1 NSCCT, 1 BEP, then I guess that also will cover the, probably it should cover the violation.
Right.
So next question is to me only. Yeah. What is the reason of loss of testicular sensation? So if you see in clinical practice, if the tumors are very small, okay, they are not occupying the full testis, then there is some sensation. If you compare both this side and that, I mean the left and the right side, or the normal and the abnormal one with the cancer. But when the tumor starts growing and it occupies the full testis, big tumors, obviously more than occupying 100% or 80-90% of the testis, then what happens is the tumor start eating into the afferent nerves, and then the sensation is itself lost because of that.
Our last question for Dr. Sudhir sir. Sir, multiple times there was chat on, as well as on Q&A, this question was raised. Non-regional lymph nodes are staged as, and I think Dr. Ganesh sir already answered 2 times that they'll be staged as M1A. So do they get staged M1A irrespective of whether they are de novo or post-scrotal violation?
Yeah, see, de novo they can occur because of the retrograde. Even the inguinal lymph node can occur because of the retrograde spread. Even in advanced disease, post-scrotal violation is a different disease. It's altogether a different situation. So here, lymphatics always already have been violated, so they can occur in the event without retrograde, and they probably may not represent the M1 disease. If you have small node in the retroperitoneal, node in the inguinal violation. Scrotal violation, I don't think they can actually go to the inguinal node at all. So if it is a non-regional lymph node with a scrotal violation, I think that will be as a de novo only. Scrotal violation will not cause so fast into the inguinal or even iliac. Iliac, you can forget. They are actually retrograde. This can occur when the patient has had inguinal surgery. Then definitely the inguinal lymph patient can come as a lymph node, inguinal lymph node, and the retroperitoneal lymph node. So de novo or post-scrotal violation, both I think I'll take as non-regional lymph node as a M1 disease.
Thank you, sir. So thank you all examiners from my side for this Q&A session. I now ask our IASO Secretary, Dr. Sharat Desai sir, to please give his vote of thanks. Sir, you are muted, sir.
Oh, I'm sorry. Thank you, Srijan, and good evening, everyone. Dr. Mandar, you have presented the case very well, and you have steered very smoothly through the IASO, through all the questions. Testicular cancer is not very common, and it doesn't follow the same rules and regulations like the commoner cancers, like the head and neck cancer or the breast cancer. So we cannot extrapolate any management of the commoner cancers like head and neck, breast. So it has got a unique it is a unique disease, it's a unique form of management, and you have done very well. Dr. Ganesh, you have, we have all had a great time because of your presentation. You were very brief and simple, but it was very beautiful presentation. You have simplified the topic very well for the benefit of the students. And I also thank Dr. Sudhir Rawal sir and Dr. Ashish Singhal sir for their enthusiastic participation. You all have brought charisma to today's session. I thank you all. Finally, our participants, our IASO members, and our students who have joined today, I hope you have all liked the class and you have all enjoyed the session. Please keep writing to us. Please keep informing us. And we will want to have a feedback regularly. And do become members of the IASO. Our next meeting is on the 17th of June, 7 p.m. Same time on the same platform. Please join again. I finally thank you, Dr. Srijan and Dr. Chaturvedi sir, for today's masterclass, for putting in all the hard work. I also thank our past presidents, Dr. Sarangi sir, Dr. Kotari sir, and Dr. Rajaraman sir, who have been continuously working for the masterclasses and who have been doing a great job. I also thank Dr. Arnab Gupta and my colleagues from the IASO who has supported this program, and because of which we have been doing a great service to all our students and to all the oncologists in our country. So thank you again, and goodbye to all of you. See you again. Stay safe and stay healthy.
Thank you.
Sharad. And just like every time, a very quick thank you from my side. Wonderful faculties, wonderful examiners once again. It made the postgraduate class really very meaningful. They were a different dimension altogether. So it was really enjoyable. And the presenter did very well. And the organizers, once again, thank you very much for carrying on with the show. Everybody have a nice rest of the evening. Thank you very much, Sharad, as well. Thank you.
Thank you, everybody.
Dr. Arun. Thank you, Dr. Rahul, sir. Thank you, Ashish.
Thank you.
Thank you very much. Thank you to all of you. Thank you.
Thank you, Dr. Arun.
Thank you, everyone, and we wish you a good night. We'll end our
Good
meeting.
night.
Thank you.
Good night. Thank